Good evening, friends. We have put up the second case now for discussion, and it shouldn't end up being just a discussion of the images, which because we don't treat images, the patient as a whole has to be understood. Now, this was a 55-year lady that had presented with dysphagia, which was worsening dysphagia for the last 25 days. And history is very important in these patients, and don't jump to a CT scan or the X-rays or the barium studies. First, take a good history. Patient doesn't give any history of cancers in the family. She had a hysterectomy some years ago, and a patient who's come with dysphagia, you need to take history of any ingestion of corrosives or any intervention in the past or any history of reflux disease, which is important. And there is also a relevance, especially in this part of the world, to take a good history of tuberculosis, which, although unusual in the West, is not so rare in this part of the world. And secondly, remember, esophagus, like any other tube, has obstruction due to causes within the lumen, causes in the wall, and causes outside the wall. So we have entities that are inside, and those that are in the wall, which is in the form of strictures, and outside it could be many, like we have the webs, the aberrant vessels, we have the lymph nodes that can cause the paraesophageal lymph nodes or parapretracheal lymph nodes, thyroid malignancies, and also any other malignancies that can press it from outside. So, like any other tube, that would be the picture. So, one should not just jump to diagnosing them as cancers or achalasia cardia or something nasty without finding out the history. It's important to find out which part of the country they are from. This is common in the northeast, and also is common in the countries like Japan, where that's why you have most of the important studies and articles published from Japan on esophagus, and they are specialists in three-stage surgery for this, three-field surgery for esophagus. The books on esophagus by Akiyama, Takahashi, etc. That's why they're popular. That's where the disease is more common. That's cancer esophagus. So I wanted to give that detour so that you understand that it's not just the X-ray. I'll come to that later. So essentially, there was a request also from some students for dysphagia class. So I would be more interested in uh, a good history. There is very little to examine, and the and then I'll have the investigation. So one shouldn't jump to investigation straight away. It should be a good history and examination of especially the cervical area for any lymph nodes, abdomen for same old system, T for N and for M, and history also for T for N for M. So for T, you take the history of how big the tumor is, how fast it's growing. Esophagus unfortunately has a very narrow lumen, so the manifestation is usually dysphagia. Now, I'll come back to dysphagia again, and I'll keep coming back off and on as I go. Look for, so we cannot really examine for T because it's not an accessible part, and one is usually relying on indirect evidence to make a diagnosis, and therefore a good history is paramount. So, what history would I take? I'll come here later. First of all, for how long does he have it? So, duration. Whether it is for solids, I mean to liquids and solids, what do you have the dysphagia for? We all know that initially for any mechanical obstruction, mechanical I'm saying, for any mechanical obstruction initially the dysphagia is to solids, and later on it will be to liquids, and then it will be a complete dysphagia, and that's no rocket science. It is gradually the narrowing that is happening, it is getting compressed or filled. So initially this time solids are a problem, liquid can go, then even liquids are a problem, and then finally there is a complete obstruction. So this is how it will worsen. Accordingly, therefore, the history would be, initially the patient would say, I had no problem taking liquids. Then I had problem taking even liquids, and then now there is a complete obstruction and I'm not able to take it. And one should not confuse it with odynophagia, which is painful swallowing that can happen due to inflammatory conditions also. And even dysphagia can happen due to inflammatory conditions. But if it happens due to inflammatory conditions, there will be features like pain and other symptoms which are found in inflammatory disorders. Now, so duration is important, and its pattern is important, which we've just handled, to solids or to liquids. Now, if there is dysphagia to liquids first, and solids don't produce dysphagia, naturally you're looking at not a mechanical cause, right? This was mechanical, this is not mechanical. So this would be some sort of a neurogenic factor. That is, if it's a light object, it will be blocked, and solid, by virtue of its weight, will go down. And this history becomes extremely important to make a diagnosis of achalasia cardia. Well, so that's an important cause of dysphagia, which must be excluded, and history has to be therefore meticulously taken. Then more things. There are conditions where there is a dysphagia due to narrowing. If there is an atresia, which happens sort of like any tube, the obstruction or the dysphagia could be due to some congenital causes also, which I didn't cover here because it was not directly relevant, but that will complete the laundry list, so I just take it. Congenital naturally is atresia, and this would usually happen with teofistula, or there are various types, we are not going there, that's congenital. The other is acquired. Naturally, it happens later. Here the baby is born with it, and there is a surgery done, and there is a system of testing by using the nasogastric tube to look for the distance, and there are various types. Whether it could be high fistula atresia here, it could be low one with a connection above. So this is a separate topic, but you should know about the congenital causes. And in acquired causes, you have, as I've mentioned a few, you have benign causes and malignant causes, which is of course more of a case here. Benign can be, I've already described a few, so to repeat it, it can be like Plummer-Vinson syndrome, many things, webs, right, which are in the neck. Anomalies like you can have a large aberrant subclavian artery which applies pressure from outside. And then of course there can be inflammatory conditions like esophagitis or reflux esophagitis, which, like inflammation, heals by fibrosis, any inflammation, and leads to stricture. Then you have other conditions like, now strictures, congenital strictures we already covered. Acquired can happen following corrosive poisoning. That's why that history become important. So corrosive poisoning, or they can be traumatic, post-traumatic, post-trauma. That is, you've done an endoscopy, so this could be iatrogenic and you've caused a damage. Or in trauma, there is an injury to the esophagus which has healed by fibrosis, can produce stricture, or they can be some parasitic infections, Trypanosoma cruzi, which produces Chagas disease. I'm sure you remember that. Just to complete the list, That's also a cause. So there's so many benign causes, so you can't just jump to malignancy straight away. Although err on the side of looking for malignancy, you need to exclude it. Exactly, it is exactly on the lines of breast disorders where you need to exclude malignancy. So that's the history part. I've covered most of it. There could be some parts remaining, and you can always fall back on the logic which I gave you. There is a tube which can have a problem inside. So in the lumen, in the wall, or outside the wall. In the lumen, foreign body, growth, right? Polyp, etc. In the wall, strictures, which could be congenital and acquired. Congenital I've already covered separately. Acquired strictures can be post injury, which includes even corrosive injury or iatrogenic trauma, as I said, or they can be inflammatory, post inflammation, which could be esophagitis, right? They could be related to um, any in fact inflammation, and part that I've already covered, congenital and acquired. So strictures will come in here, and of course the important one, that is malignancy, malignant stricture. Now outside it can be a lymph node. We've talked about the, there is a term called as globus hystericus, which is seen in young girls who have an element of like a ball in the throat. So they have also got dysphagia. So there are just so many causes. I tried my best to recollect and put as many as I could. But importantly, the two major conditions that we look at are achalasia cardia and malignancy. And they're the ones that you need to look at carefully. As I mentioned, in any mechanical obstruction, especially malignancy or any mechanical obstruction, it will be solids, then liquids, and then complete. This is mechanical obstruction. In neurogenic obstruction like achalasia, we'll have liquids first, then of course solids almost never happens. So by that time the patient would manifest. And classically, especially in achalasia, it goes down like you have a narrow beak type of appearance here, which actually looks like a bird beak appearance. Anyway, while the benign strictures are short and there is no irregularity that you'll observe, in a malignant stricture there is usually shouldering and they are irregular, and they end up in a thin, narrow, long stricture. That's why that looks like a rat tail. So looks like a back of a rat, and that too a rat which is not too happy at the back. It has been rogered. You can see this irregular. It's a rat that has been hit on the back. You can see. So rat tail appearance with the back of the rat having been rogered. Okay, easy to remember. So if you have a patient with dysphagia, take a good history and don't miss it. You need to then examine carefully for, basically, as I said, looking for an obvious cause, which may be rare. Like you have a big thyroid, you have a big thyroid, or you have a big neck lesion of any kind. So there's an obvious cause. So these are obvious reasons which don't demand any attention or effort. You can look for them. And then the second thing is look for cervical lymph nodes, which indicate some malignancy. And then finally you will look for the third part, which is the M part. here, and that will be for metastasis. So distant metastasis or metastasis to the lymph nodes. This is what you look for. So we look for T, we have looked for N. T mostly is 90% history, because you will have very little, only 10% findings on examination. Then looking for nodes, you need to examine neck, abdomen. For M, look for liver. And remember, if there is a lymph node in the abdomen for a cervical esophagus, that will be taken as metastatic disease. So it should be the regional node that we are looking at. So this should be a regional nodes. It shouldn't be non-regional node, because non-regional node is a different staging. I'm just touching the dysphagia and I've kept it short for this purpose. So it may not be a complete complete description of the whole thing. Now I think we can then look at what do we do. We have a case of dysphagia with the history that we have just provided. You'll do investigations to confirm diagnosis, to stage the disease, and to treat the patient. Now what can you do to confirm the disease? This is a tricky scenario. After you've taken a good history, don't confuse the patient and don't tell the patient that you've got something nasty. Now most people have a doubt here whether you do imaging or you do contrast. I mean including this, sorry, or you do endoscopy. Right? It's a commonly asked question. Imaging would be some contrast, so it includes contrast. And endoscopy is to actually get the biopsy, because without that, how do you confirm your diagnosis? So when you're dividing it, be flexible in answering and say that I would like to prefer to do the imaging and then follow it up with um, basically endoscopy. But the issue with imaging is most of us would order a barium swallow. Now barium swallow, as is given here, is a very useful investigation. It is able to give you an impression of a cancer, or it rules out an achalasia, or it rules out a malignancy. Once that is done, the only problem is if you follow it up with upper GI, or you follow it up with endoscopy or esophagoscopy, the barium has to be clear, otherwise it may turn out to be a whitewash. You may see all white, because barium takes a while to go. It may line up the mucosa and you may have a difficulty. Although it's not such a real problem, because you can always, these days we use a very thin barium. But the problem in these patients is, since there is obstruction here, it piles up and it may take a while to go. So a lot of people are not truly very happy doing the barium swallow first. But without barium swallow, I mean, you should in principle always do on non-invasive tests first, so that you don't end up doing endoscopy and finding nothing in the esophagus and it is outside the esophagus. There is a good case for doing, depending on where it is, ultrasound saying the neck is all right, ultrasound of the abdomen is also important to look for any, the status of the liver, lymph nodes, and in this case she's had hysterectomy, so look for any ascites and the peritoneal, or the, as they call it, the pouch of Douglas, for any deposits, and the peritoneum any deposits. So you can do imaging. Can you do contrast in a CT scan? A lot of people like to do that straight away, which is more specific and it's able to show the thorax also along with it. And it depends where the esophagus is. Most of us have actually got barium swallow done beforehand. And let's face it, in this case, the same situation. you have a barium swallow here, and you should describe it as a barium swallow, where classically there is a structure that's long, and this part is also narrow. Usually you find peristalsis, which is but short segments. This is a long segment, and you can see there is a rat tail appearance, and this is classical for this especially is the rat tail appearance. And if you notice, it isn't looking like a regular margin here, it's irregular. This being an elderly lady with a short history, I would suspect it to be malignant. And even in an X-ray that comes along, you can look at the lung for any metastasis or any effusion, which can help you make a diagnosis. So barium, we had just given you this barium to study and assess, but I've discussed with you the diagnosis and the differential diagnosis because we don't treat the images. So for the metastasis, you can do a ultrasound abdomen, CT thorax, which I mentioned here, which you can see also, and finally, of course, we will have a diagnosis when we do the endoscopy, which will let us know as to what is the type, grade, whether there is malignancy firstly, then the type, the grade, and accordingly this will help us. And also there can be some multiple lesions, synchronous, and the most important thing that you can do is, which you're doing, is a biopsy, and that can give you this information. Based on that you would plan the management, and naturally this is a case with a mid segment malignancy, which is becoming more common. It used to be the more common in the West. We always had the lower part getting involved more, and especially the GE junction close by it, which is a different cancer. This would be addressed as a, so therefore it will be discussed as a case of dysphagia, which is probably malignant, suggesting carcinoma of the esophagus, and therefore we need to investigate on those lines. And once you've done this, and once you've staged it, you have options to put these patients on some kind of, they need more investigation. This dysphagia needs to be managed, and if it is resectable, the approach could be different. In the upper one third, broadly, it's radiations. In the lower one third, it is mostly, since it is almost on the lines of stomach, we offer surgery, and it's amenable to transhiatal esophagectomy. The mid one third, we generally have a combination of both, and you can use the Ivor-Lewis approach, which allows you to go through the thorax, resect, and then we make a tube out of stomach, and we can pull it up in anastomose. In a classical transhiatal approach, I'm not discussing the lymph node dissection, which is 2-field versus 3-field. The Japanese like to do 3-field, where actually the entire all groups are removed, including the carinal nodes and the cervical lymph nodes also, and the paraesophageal nodes here. So that's beyond the scope of this, but you should understand that there are various options for surgery in this case. A lot of people like to do a transhiatal esophagectomy, where we have an abdominal approach through which you dissect out the stomach properly, and then since we have to, we also try and dissect the esophagocardiac junction, and to see that, to assess through the crust the excess that we are going to have towards the growth. And then finally we have a stomach tube cut out, which is based on the gastroepiploic pedicle, rather than left gastric is ligated, and then we make a tube out of this. Now the dotted part joints is taken out along with the esophagus, right? just to show you. This part is going, so this is the part which will be uh, used for making the tube, and we will do some bit of jug ready to make it as long as we can, and this requires cauterization which will lengthen the this will mobilize the duodenum, and also as you pull it, this is pylorus. A lot of people like to make it incompetent because this is now going to work like yes, so it is pulled up and pylorus comes to lie somewhere here, and this tube goes up into the neck. And what do you do? Once you've done this part, you can go to the next step. The yellow thing is what we are indicating as the malignancy. The malignancy is we mobilize. Usually the lower growths are amenable and they are easier to remove. We clear it off, and we have to be careful about pericardium, the pleura, and the azygous vein which crosses over. It can actually bleed, and the process is quite blind, which is why a lot of people don't recommend it. Ivor-Lewis has an advantage that you open up the thorax and you do it under vision, and you can actually clear off the lymph nodes along with that. In this technique, the lymph node clearance may not be as good, and a lot of us like to put a scope in and see and do it under vision. So it is possible to do that. It becomes less blind if you use if you do a scope assisted transhiatal esophagectomy. And so you've dissected it. This segment is all free, that means. And then we have an approach in the neck. What do we do in the neck? We have the patient's position. In the same position, we make an incision hockey stick in front of the uh, sternomastoid, and like you do for thyroid, but we extend it upwards. You deepen it, go in between the strap muscles and the thyroid actually. So you ligate whatever you can, and you reach, then you reach trachea, and on the left side it is low below, and I mean you can share, we'll share with you the video of the procedure so it will be easier. We dissect it, take it on a tape, and then dissect from above, from below, so above, below and above both, and finally we disconnect it here, and what we do is at this end we usually leave a long nasogastric tube tied to it. So it goes in, or earlier I was using just a thread, a long thread tied to it. And then what do? We have this end is to go, we've already disconnected it. This is the disconnected part. It is at the end when you have tied it, you got a long suture here also. So this goes, it's taken out through the neck. I mean, this has to go here, so I'll just show you again in this picture. So we have esophagus transected here, and we have, this is the esophagus and the part of the stomach that we have to remove. So once we have mobilized and disconnected it, we have got this disconnected, we make sure that it's clear and we deliver it out. And this tube that I have tied with it, or the thread, comes down with it. So in the next picture you will see that the esophagus is, the whole thing has come down, and we still have the thread here which is hanging, which is connected upwards. The thread is still connected in the neck. So we remove this part and tie the tube that we have newly created tube to the thread and pull it up in the neck. And once we have pulled it up in the neck, the anastomosis is done between the cervical esophagus and the newly created tube, which I'll draw with a blue now. There are many finer points in this. This is all connected, and pylorus would be somewhere here as you see, and we got this going down like this. So this is the erstwhile stomach, which is a tube that is based on gastroepiploic vessel. So it is based on gastroepiploic pedicle, which was here. So basically, we remove this part after disconnecting from here, but at this end, it can have a lot, otherwise it's very cumbersome to pull it up. So it comes down with it, and then we tie that thread to the tube and pull the tube up in the neck. And in the neck, we do an anastomosis, leave a drain there, abdomen is closed, and that's the transhiatal esophagectomy. In an Ivor Lewis, we have a thoracic incision. Thoracotomy is done after laparotomy, right? So we can, I mean, we make the same tube, okay, and the resection is done the same way. We resect it, clear up the nodes, so that is an advantage, right up to the, I mean, where the recurrents are going up, you clear along the recurrent laryngeal nerve. That's what the Japanese want to do. Then they do the dissection in the neck. So the entire, that is what makes it 1, 2, and 3 field. So they clear off all the lymph nodes, and then we can anastomose in the thorax. So in Ivor Lewis, where is the anastomosis made? In the thorax. So it is suitable for mid thorax. Transhiatal is suitable for lower 1/3. I have briefly touched on the procedure. It, of course, is very difficult to make the whole thing uh, cleared without assisting, and maybe I'll share with you my video on esophageal cancer surgeries that we have done. And then we leave a drain in the abdomen. Here we need a tube thoracostomy, and we need to drain the thorax. Where is it gone? Here. So this needs a tube afterwards. It has a risk. What is the risk? It's very obvious. It can leak in here. The problem with the transhiatal is if at all the leak happens, it's in the neck. And if the tube is made well, it's a very useful procedure, and we find it most useful, and we have used it the maximum. And up to mid esophagus, we can actually use our fingers to break it. That's the only problem with it. Since we have used scope, it becomes easier to go high, and you can see all the vessels, because the vessels are feeding directly from aorta into the esophagus, and you can clip them under vision. That makes it much better. And like I mentioned in the beginning, azygous means it has no pair, right? Azygous is a single vein that crosses over, and it can, if it is damaged, it's torrential hemorrhage. And the other complication is pleura is ruptured, the pneumothorax, so leave a tube there. And pericardial rupture can be a problem, and the the veins also relating to heart can be an issue. So we have advantages and disadvantages of both. Most people would do transhiatal. The most common site that we observed in Indian scenarios is low 1/3. Although it is changing, it is getting higher, even in this subcontinent. You know, the reason why they don't actually know it, earlier it was attached to reflux esophagitis in this part of the world. A lot of us know H. pylori is a factor too, but one doesn't know exactly. It is related to many factors, and it's a cancer where mostly we were earlier not thinking of cure, and 5-year survival rate was less than 20%. It is just a dysphagia that was treated by the surgery, and a lot of these patients won't live beyond 2 years or 3 years or 4 years. It is also one of the champions of the army of death, as they say. It improved with the neoadjuvant chemotherapy coming into vogue, and the neoadjuvant chemotherapy can actually make the dysphagia better and the outcome of surgery better, and the survival rates have improved. So this is one cancer where survival rates have improved with neoadjuvant chemotherapy. And surgery alone, if you're asked a question, is to basically was earlier taken to be to treat dysphagia. Although it is changed with the Japanese, but they get their cancers early, and that is why they are able to do a better job. They also do endoscopic mucosal resection, where they can, on screening, if they find it, they can do by instilling saline under this submucosal plane. It rises, and then you can just chisel it off. And this is one scenario where endoscopic ultrasound is extremely useful to make a diagnosis in early cancer. and in some sort of a screening happening, especially in that part of the world, they've been able to pick up those early cancers. Barring that, most of the time, by the time you make a diagnosis, and if there is dysphagia, naturally there is obstruction, and the growth is already, it is not early. So we don't get to see early cancers. And if you get a growth, say, in the lower one third of esophagus with a node in the cervical region, you're already looking at a metastatic or distant disease. So one has to be extremely, extremely positive in dealing with it and counsel the patient accordingly because they really suffer. There's a lot of cachexia in these patients, and many a times the best approach is as they come to do a feeding gynectomy and put them on neoadjuvant chemotherapy, look for a good response, and the response is assessed in terms of relief in dysphagia, and also one can do a imaging, whether it's contrast enhanced CT scan uh, or more advanced procedures. In the role of PET scan, one is not too sure. Now, feeding J, neoadjuvant chemotherapy, and then maybe you can do surgery. But there are options which I have just discussed with you. They need to be exercised depending upon what you do. One complication of transhiatal esophagectomy, which I did mention, was in the neck there can be a leak, and that is a disaster, which then would need, you need to put a good drain, and often this tube is devascularized, and that again leads to a leak into the mediastinum, which causes mediastinitis, another high mortality complication. But the cervical leak would have to be managed by taking the esophagus out, which is called esophagostomy, and doing a feeding jejunostomy to disconnect it completely. So that's the long and short of it. A case of dysphagia, which looks very much like malignancy, with based on the history, with the points in history are short history, quickly, rapidly progressing dysphagia, and on examination there's nothing per se. Patient is cachexic, and the performance status has dropped. Nutritionally, the patient is weak, and barium swallow is suggestive, so we should go in for an endoscopic biopsy, which would establish the diagnosis, and it doesn't look early, so it would be a good case to do a feeding jejunostomy, neoadjuvant chemotherapy, and planning it. And always answer that we'll discuss this case in the MDT, which we will be doing next Tuesday, and take a call on this case. Thank you very much.